From the dark jungles of Southeast Asia to the midnight sun of the Aleutian Islands, join Dr. Patrick Bays as he travels the globe in search of the next shockingly true surgery story. Today's show is sponsored by CurPoint Orthopedic, Seattle's premier cell-based medicine center. Your body, your cells. And now, CutSheet.
In the summer of 1990, Mount Pinatubo, the world's second most powerful volcano of the 20th century, started to stir for the first time in over 400 years. It began at approximately 4:30 p.m. on July 16, 1990, with a massive 7.8 magnitude earthquake on the Richter scale. The earthquake was centered about 60 miles northeast of Mount Pinatubo. Now, to put that into perspective, the San Francisco earthquake that occurred in 1906 also had a magnitude of 7.8 on the Richter scale. That San Francisco earthquake caused over 3,000 deaths and over $500 million in property damage. And all of that occurred in under 1 minute. The earthquake stemming from Mount Pinatubo struck northern and central Luzon Island in the Republic of the Philippines. And among the areas most severely affected were the mountain cities of Baguio, the coastal areas of La Union, and the central plains around Cabatuan, where former Allied prisoners of war camps had been maintained and located during the Japanese occupation during World War II. Now, Baguio was a beautiful recreational city set high in the mountains and was often frequented by U.S. military families who were on vacation. Baguio suffered major damage to 28 buildings, and among them were 3 hotels that were destroyed, ensnaring guests and employees under the falling debris. 2 schools were also severely damaged, trapping students and faculty members inside. And a nearby factory building collapsed and burned to the ground, killing the helpless workers that had been trapped inside. Baguio was completely isolated from the rest of the country for about 48 hours. All electric, water, and communication lines were completely destroyed. And the city was inaccessible by land because of landslides and also inaccessible by air, except for helicopters, because of damage to the airport. Food and fuel were scarce, and because the hospital was damaged, the patients had to be relocated under tents set up in open areas in front of the hospital. Now, during the first 48 hours, rescue teams consisted of local volunteers, mainly miners and cadets from a local military school, who worked in tandem with picks and shovels to help dig people out. My first patient that arrived at Jungle General Hospital was a middle-aged teacher named Michael. Michael had been brought in from one of the schools that had collapsed in Baguio. Michael had sustained a severe injury to the palm of his right hand when a large piece of metal had fallen from the ceiling of a collapsing building and sliced the palm of the hand over where the flexor tendons lie. The hand had been wrapped in gauze by our medical triage teams, and after unwrapping the gauze in the emergency department, the first thing that I noticed was the posture of Michael's fingers. Now, if one takes a normal hand with normal flexor tendons and places it palm up on a table, there's something called a natural flexion cascade of the fingers towards the palm. The small and ring fingernails are closest to the palm, while the middle and index fingernails are a little further away. But in Michael's case, I instantly noted that all fingers remained straight, which indicated that Michael had severed every flexor tendon going into the palm of his hand that basically caused the function for the index, middle ring, and small fingers. Now, there are 2 flexor tendons to each finger. One tendon flexes or bends the joint closest to the fingernail. That's called the flexor digitorum profundus, and it bends what's called the distal interphalangeal joint. The other flexor tendons bend the other 2 finger joints, and that's called the flexor digitorum superficialis, and that will bend what's called the proximal interphalangeal joint and the metacarpal phalangeal joint, and those make up the 3 joints of the hand. So in this case, Michael had an inability to bend any of those joints because the finger tendons that move those joints were all cut or severed. In orthopedic surgery and hand surgery, this area where Michael had sustained these injuries is called no man's land. because it's the area of the hand that's most difficult to fix when tendons are lacerated. And in Michael's case, he had severed all 8 tendons. But because these tendons are in no man's land, there were also arteries and nerves that run through the same territory. And thus I had to carefully determine which of those structures were also cut, and which of those structures would have to be repaired using a microvascular technique. My examination of Michael also indicated that some of the nerves, in addition to the tendons, had also been cut because he lacked sensation to several of his fingers. That said, the fingers appeared to be perfusing with blood, so at least they were getting oxygen and nutrients. I took Michael to surgery and carefully inspected the entire hand after making an incision that expanded the area that had been cut. And sure enough, as I looked in, 8 of the tendons were completely severed, as were 3 nerves supplying sensation to the fingers. Surgery in no man's land is always a challenge because it requires meticulous technique and attention to detail. One of the major problems in no man's land is that there are pulleys there that keep the tendons in place. These pulleys needed to be treated gently, or as one of my instructors used to say, soft tissues need to be treated softly. We do that so that these pulleys don't develop scar tissue and impair the tendon function. If it does develop scar tissue, the tendons can get stuck and the fingers won't move. In this case, I used special lenses that greatly magnify the structures so that I could match up each of the cut tendons with its mate, almost like matching a pattern together. The tendons were matched up and sutured with a type of suture that works best for tendons. Once the tendons were matched up and repaired, I turned my attention to the severed nerves. These structures were also carefully aligned and sutured with a suture about the size of a human hair. Once repairs were completed, the incisions were then closed and the patient was placed into what we call a cobra splint to protect the repair. After fixing Michael's hand, I took him to the recovery room and wrote orders to admit him to the floor. Once he was stabilized and transported without any difficulties, I returned immediately to the emergency department, where the patients were still coming in fast and furious. Now, most of the injuries involve fractures or dislocations, but in some cases, the injuries involve what are called crush injuries. Our hospital team worked in shifts to care for the injured, and my partner and I, my partner's name was Brian, worked around the clock trying to fix fractures with stainless steel plates and screws that were affixed to the outside of the bone, or in some cases using a technique called an intramedullary nailing, where we take a stainless steel or titanium nail and insert it through the inner portion of the bone marrow canal for the fractured bone. These typically stabilize the fractures well enough that many times patients can start walking within a day or two. Most of our patients were found to be stable enough after fixations or treatment to be discharged back to their homes within a week. There was, however, one additional patient that we had not yet taken care of. His name was Sam, and he had still been trapped under the debris and had been trapped for almost 2 days. Now, Sam had alerted rescuers that he was still alive by tapping on a water pipe with a piece of metal. The rescuers knew that they were racing against the clock to save Sam. And to the best of the rescuers' knowledge, Sam was the lone survivor that had not yet been rescued. And so Sam's plight was being followed closely by people from all around the country. For our part at Jungle General, we were on standby, and from an orthopedic surgical standpoint, both myself and my partner Brian were well aware of the types of injuries and complications associated with crush injuries. These can be some of the most devastating injuries that are known. But until Sam was rescued, we would just have to wait and see the total extent of Sam's injuries. And so as we continued to wait for Sam and the status of Sam, we continued to see patients at Jungle General as they came through the doors. Once I had gotten Michael taken care of, I went back out to the emergency department and was asked to see a 60-year-old female patient whose name was Wanda. Wanda had been thrown down the flight of stairs as a consequence of the shaking from the earthquake and had landed violently on her right hip. She had suffered immediate onset of pain and was unable to walk or bear weight. Well, luckily, Wanda had landed in an area of the building that was still accessible to the rescuers. And so once they were able to get to her, she was stabilized and transferred to Jungle General for care. Examining Wanda, I saw that her right lower extremity was foreshortened or shorter than the left, and was also rotated in a funny way that didn't look like the other side. And so immediately I started thinking that she might have a hip fracture. Now, anatomically, the hip is a ball and socket joint. So when an elderly patient falls and lands on the hip, it can often break or fracture. In many cases, this is associated with osteopenia, or loss of bone calcification. And this can occur with age, particularly in females. There are 4 basic types of hip fractures. The simplest type involves a fracture of the hip joint just below the femoral head. This type of fracture is called a subcapital fracture, meaning below the head. On X-ray, this appears as a fine line, and many times the head of the femur is impacted on the neck of the femur. Much like a person with a short, thick neck and a big head appears to look as though their head is sitting on their shoulders. These subcapital fractures are quite easy to treat by the insertion of 3 parallel screws that are called cannulated screws. And we do this through about a 1-inch incision. The screws are inserted across the fracture line and into the femoral head of the hip by using a specialized X-ray machine called a C-arm, because it's shaped in the letter C. Normally, this procedure can be done in about 15 minutes, and the patient can bear weight almost immediately. The second type of hip fracture is called an intertrochanteric fracture because it occurs between 2 large outcroppings of bone called the greater and lesser trochanters. Now, these fractures are often displaced or malaligned and have to be put back into the correct position by placing the patient on an ingenious device called a fracture table. The fracture table allows the surgeon to slowly put traction on the hip by using a ratcheted traction system. Essentially, the surgeon is getting the leg back out to its normal length and correcting for rotational anomalies that are caused by the fracture. Once this closed reduction or restoration of the bones to the proper position has been performed, the fracture is then stabilized by inserting a specialized plate and screws or some sort of a short intramedullary nail into the hip region to stabilize the fracture. This entire procedure is also performed using the C-arm, and these fractures can be fixed in about 30 to 40 minutes. The third type of hip fracture is called a subtrochanteric fracture because it is located below or underneath the trochanters. These types of fractures can be quite challenging because they are frequently in multiple pieces or comminuted and are much more difficult to get back into proper alignment. Now, like the trochanteric fractures or the intertrochanteric fractures, these subtrochanteric fractures are repaired with either plates or screws or with a short intramedullary nail. And either fixation method requires, again, the use of the C-arm. These types of fractures can take a little longer to repair, usually an hour or even longer than that, and you might lose a little bit more blood because of the nature of the fractures and where they're located. The fourth type of hip fracture is a fracture through the neck of the femur. Now, these fractures are nearly always dealt with by removing the patient's own femoral head and inserting a metal prosthesis, much like one would do with a hip replacement surgery. These cases involve a long incision and involve dissection all the way down to the hip ball and socket joint. And you actually put in something that looks like a corkscrew to take out the patient's own femoral head. The head is taken out of the socket and measured using a specific type of a device that tells you exactly what the diameter of the head is. And once you've determined that, you determine the size of the femur or the femoral shaft, prepare the femoral shaft, and then insert a metal prosthesis using most likely bone cement. Sometimes in patients that are younger, we'll use what's called a bipolar implant that has a plastic device that will preserve the socket more efficiently. These types of procedures, these hemiarthroplasties, usually take about 45 minutes to perform. In the case of Wanda, the x-rays revealed that she had the type of hip fracture that could be repaired with something called a dynamic hip screw, or DHS. Her fracture was of the intertrochanteric variety, which is much easier to treat than the subtrochanteric variety. These DHS devices, or dynamic hip screws, have been around for a long time and are part of the orthopedic surgeon's toolbox. Though there are currently a number of orthopedic surgeons now that use the short nail, but back in the time when I was fixing Wanda's hip, we were using what was called the DHS. In Wanda's case, she was taken to surgery and I inserted a dynamic hip screw under C-arm visualization. The procedure went well and took about 25 minutes. And the day after surgery, Wanda was up with physical therapy and was already starting to put partial weight bearing on her leg. She progressed rapidly, and within a week or so, she was well enough to be transferred to a skilled nursing facility. Soon after Wanda had been taken to the recovery room after her hip surgery, I received yet another injured patient from the earthquake. And this patient truly fell into the category of the shockingly true surgery story. As many of the other patients had been crushed by falling debris, my next patient had an entirely different cause of injury. The man's name was Limon, and he told me that he had been on the top floor of a 3-story building that was beginning to sway violently during the earthquake. He believed that the building was about ready to collapse, and so he crawled out the window and hung on to the window pane as the building was swaying back and forth. Well, the building did not collapse, and unfortunately, Limon was unable to pull himself back through the window, and so he hung there for, he told me, about 5 minutes before he could not hang on any longer and eventually lost his grip and plummeted to the ground. He said he landed feet first, but in doing so, he injured both of his heel bones, and by the time he arrived at Jungle General, his feet were already markedly swollen and were beginning to blister. X-rays showed that both heel bones were crushed and that the joints of each foot were flattened like pancakes. These are called calcaneus fractures and are very difficult fractures to treat, and they often swell dramatically. And so was the case with Limon. So we had to put him in soft cotton splints with his legs elevated, and we were going to give him several days of elevation and then take him to surgery to repair the heel bones with specialized plates and screws. And I figured we would also have to use some bone marrow graft to pop the bones back up to their normal position. And so even though we were busy taking care of our patients, Michael, Wanda, and Limon, we were still concerned about Sam and his recovery. We knew that he had been buried for a number of hours, and we were making preparations for how we would care for him the second that he was recovered. We were confident that the rescue teams would get to him in time. Though Sam had not yet been rescued, we assumed that he had sustained what are called crush injuries, and we knew from experience that crush injuries can be some of the most devastating injuries known in orthopedic surgery. And that's because the crush injuries not only cause fractures and dislocations to the bones or joints, but they can also cause extensive damage to the body in general. Now, during World War II and the bombing of London, there was a condition that was coined that was called the crush syndrome. This was first described after bombing victims presented to the doctors with dark urine and very swollen limbs and extremities. Even though many of these patients initially did not appear to be very sick, they subsequently rapidly deteriorated and died. In other national disasters, such as massive earthquakes or anything where individuals are buried under debris or falling buildings, crush syndrome has been found to be the second most frequent cause of death. One major complication after a crush injury is damage to the blood vessels and nerves, and because of the loss of blood supply, the limb becomes necrotic or blackened, which may result in amputation or other serious complications. A second complication of crush injury is compartment syndrome. In compartment syndrome, the arms and legs have various compartments that are covered with thick tissue called fascia. Crush injuries can cause the muscle tissue or the broken bone to bleed, and this is called a hematoma. If this bleeding goes unchecked, it will fill the fascial compartments with clotting blood, which raises the pressure inside of the compartments. This increased pressure further compresses the small capillaries to the point the soft tissues, particularly the muscles, no longer have any oxygen flowing to them. This causes the soft tissues to die and may require an amputation if not treated in time. The treatment is called a fasciotomy. This is a somewhat brutal procedure where the skin, subcutaneous tissue, and fascia are split along the entire length of the limb. This traumatic procedure often results in the engorged muscle popping up through the incision like muffins in a tin. But though it looks quite brutal, the procedure is life and limb saving. The caveat is that there is a golden period of about 6 to 8 hours to perform the procedure. If this procedure is not performed soon enough, the damage is irreversible and may result in limb amputation or even death. A third and often fatal complication of crush injuries or crush syndrome is a condition called rhabdomyolysis. In these extreme cases, crush injuries can cause muscle tissue to break down due to the poor blood supply. Now, if the muscle tissue breaks down too rapidly, damaged muscle cells can release harmful chemicals into the bloodstream. When these chemicals build up, they can lead to kidney failure, heart failure, or other abnormalities such as blood clotting dysfunction, where the blood is no longer able to clot properly, and these people can start bleeding from everywhere in their body. It's a serious condition and requires massive transfusions of additional blood factors. After a crush injury, a person can still be lucid and conscious, and typically the most dangerous period is between 12 and 72 hours after the injury. This is assuming that a severe compartment syndrome has not yet taken hold. Once the pressure builds up to such a degree that the compartment syndrome develops, the toxic byproducts of the released tissues and dying muscles into the bloodstream begin to wreak havoc on the other organs. The best way to prevent crush syndrome is to extricate patients from the crushing force or object as soon as possible, because the longer the patient has been crushed, the worse the prognosis. And this is what we were worried about with Sam. Finally, after about 30 hours, we received word that Sam had been recovered, and the helicopter and transport team immediately went to work to stabilize Sam and to get him to Jungle General Hospital as soon as possible. Sam soon arrived to Jungle General, and our medical team went into immediate action, and within minutes, we had inserted large bore IVs and drawn labs. X-rays were taken of Sam's heart, lungs, pelvis, and extremities, and a heart monitor was hooked up to assess his heart function. A catheter was inserted into the bladder to monitor urine output, and another catheter of a different variety was inserted to one of Sam's arteries so that we could continually assess his oxygen level and his cardiovascular function. Sam's initial results were not good. He was already fully in the crush syndrome, and his organs had begun to fail. Sam required massive blood transfusions as his ability to clot had gone haywire. He was placed on kidney dialysis and was perfused with a cocktail of every sort and variety of medication to keep pace with his nutritional needs as well as his total medication requirements. From an orthopedic surgical standpoint, Sam had severe necrosis to both his right and left foot and ankle regions, and unfortunately, emergent amputations were necessary to take off a portion of both the right and left lower extremities from the ankle down. I also performed compartment fasciotomies that were carried out to both the right and left lower legs, and both the right and left lower legs were fractured, and Sam was placed into something called an external fixator, basically a stainless steel tinker toy set that holds the bones in place with long screws connected to a metal frame that sits outside the body. However, after about 24 hours, we actually started to make some progress and got ahead of some of the more pressing problems that Sam was experiencing. Sam had improved and was now coherent and beginning to communicate, though he was still extremely weak. The good news, however, was short-lived, and it became obvious that Sam was developing a new set of complications, with one in particular called necrotizing fasciitis caused by flesh-eating bacteria. Because Sam had been buried under the building for so long, diabolical bacteria had populated his necrotic tissue, and cultures revealed that we were dealing with both anaerobic and aerobic bacteria, meaning that some of the organisms required oxygen to grow, and others grew best without oxygen. We did cultures and found the main culprits to be Staphylococcus aureus, Clostridium perfringens, or gas gangrene, and Pseudomonas aeruginosus, which is often seen in severely burned patients. All of these germs required high doses of multiple antibiotics, and all required multiple surgical debridements. Unfortunately, with each subsequent surgery, Sam was losing more and more of his legs. We continued to work feverishly around the clock to try to save Sam's life. And so we divided ourselves up into a day team and a night team. It was a roller coaster of successes and setbacks, but after about 5 days of over 10 surgical procedures and countless transfusions, we realized that this battle was one that we could not win. By then, Sam had become our hero, and his will to live was as strong as anything I have personally ever seen in my life. And through it all, there was never a complaint or any semblance of self-pity. He had transformed from victim that had survived the longest known time under debris in Philippine history and survived to a shining light of inspiration to the entire region. There were letters pouring into the hospital on a daily basis from well-wishers, and cards were sent from around the country urging Sam on. But as physicians, we knew the end was near. Sam's dying wish was to become a Marine, and so on his last day, he was surrounded by a contingent of Marines, their commanding officers, and an entire team of doctors, nurses, and other medical personnel that had cared for Sam. The Stars and Stripes newspaper was on hand to take photographs, and Sam's family was gathered around him as Sam took the oath and was sworn in as an honorary United States Marine. Sam was given his certificate and was given a medal for his bravery. And later that evening, after all the festivities had ended, Sam closed his eyes for the last time. Sam's unique story serves as an inspiration for all of us, and I think of him often when times are challenging for me. His memory will forever burn brightly as a shining example of humility and bravery in the face of insurmountable odds. To me, Sam will always be a hero. I hope that you have enjoyed today's presentation of CutSheet, and I hope you tune in next week as we delve into new and exciting, shockingly true surgery stories. My name is Dr. Patrick Bays, your host on CutSheet.